to today's webinar, Hypophosphatasia, Oral Manifestation and Management. Before we get started, I'd like to go over a few items so you know how to participate in this event. You've joined the presentation listening through your computer speaker system by default, but if you prefer to join audio over the telephone, just select phone call in the audio section of your control panel and the dial-in information will be displayed. You can submit questions at any time to our presenters. Just type them into the questions box of your control panel and we'll be addressing them during the Q&A portion of the presentation. A recording of today's presentation will be available on the SoftBones YouTube channel. And I would now like to introduce your host, Deborah Fowler of SoftBones. Welcome, Deborah.
Thank you so much, Karina. Good evening and good afternoon. Thank you all for joining us for this evening's presentation, where we'll talk about oral manifestations and management of hypophosphatasia. Before we get started, we wanted to spend a few minutes introducing you to SoftBones and sharing a little bit about our mission. Many of you may be familiar with SoftBones through our social media channels and our national and regional patient meetings, but SoftBones is so much more than just a meeting and a Facebook page. Our mission is to provide valuable information, education, and support to people living with HPP as well as to their families and caregivers. And that happens in three ways. We empower the HPP community through education, awareness, through websites, the webinars like this one, and other educational materials. We also drive research through grants and providing platforms where researchers can connect and collaborate. And we use insights from our patient experiences and dialogue to inform our efforts to educate and drive policy initiatives in DC to help eliminate barriers to access. We believe that a cure is possible in our lifetime, and it's our vision to make that a reality by supporting gene therapy and other curative research. But we need your help to unlock the key to HPP. HPP can be a life-threatening condition, and we rely on donations and sponsors for support. And as you can imagine, we've greatly been impacted by COVID-19. So how many people have HPP? It's a great question, and unfortunately we don't have the greatest answer. One of the ways that we hope to get a better handle on prevalence is through an international HPP patient registry. We partner with Stanford Research to build this contact registry, where patients and carriers are notified when any research opportunities are available to HPP patients. It's one of the best ways patients can support our organization by ensuring their HPP cases are captured. And this is for patients as well as carriers of the HPP mutations. The registry is also available in multiple languages. And so if you're interested in joining our registry, we have over 220 patients in there now. You can do it either by emailing cords@stanfordhealth.org or by calling 877-658-9192, or you can go to our SoftBones website and on the homepage click on Enroll in the International HPP Registry. We have 8 regions in the United States, and in addition to our national HPP meeting, we have at least one SoftBones region lead per region, and those region leads host their own local meetings in the communities where we live. Meetings are held throughout the year and are posted on our website, through social media channels, and also in our SoftBones newsletters. If you're interested in helping to potentially host a region meeting, please reach out to us at info@softbones.org. And without further ado, I'm going to pass the presentation over to Dr. Tim Wright. I'm going to give you a little bit of background about Dr. Wright. He is currently serving as the Bawden Distinguished Professor at the University of North Carolina at Chapel Hill Adams School of Dentistry. He's in the Department of Pediatric and Public Health and is former chairman of that department. Dr. Wright completed his DDS degree from West Virginia University and went on to pursue his pediatric dentistry residency and the National Institute of Health postdoctoral fellowship in caries research at the University of Alabama in Birmingham. Prior to joining the faculty at the University of North Carolina at Chapel Hill, Dr. Wright has authored more than 200 publications, and his research focuses on the diagnosis and treatment of developmental defects in teeth resulting from hereditary and environmental conditions, such as HPP, as well as understanding normal tooth development. Dr. Wright has served as the president of the American Association for Dental Research and is chair of the American Dental Associations and the American Academy of Pediatric Dentistry's Council on Scientific Affairs. He maintains an active private practice that includes providing care to patients with special medical and dental health care needs. And I should mention, he's also a member of our Softbone Scientific Advisory Board. So, Dr. Wright, I'm going to turn the presentation over to you. Thanks for joining us.
Thank you so much for that kind introduction. And welcome everybody out there in computer land. I hope that everybody is staying sheltered at home and is safe and healthy. These are challenging and interesting times, to say the least. And I appreciate you joining the webinar this evening. So what I'm going to do is go through some background information. Some of it is just basic dental information, and some of it's very specific for hypophosphatasia. At the end of this presentation, we'll have time for questions and answers. The format doesn't lend itself particularly well to doing that as we walk through this, but that's the goal. So just a lifetime of oral health. There's, this is something that you're going to live with and deal with, and hopefully you're going to be able to manage health, but sort of as a timeline of how we do things. So infant to early childhood, one, we're diagnosing any kind of issues or problems. One of the early presenters for HPP is early tooth loss, so that's frequently the very first thing you might see. So making a diagnosis for whatever the condition might be, talking about preventive oral health, because if you have dental issues already, you for sure want to maximize your oral health. Monitoring tooth development, so what teeth are developing, when are they erupting, those kind of issues. During childhood, we continue to monitor that. Teeth continue to grow almost throughout life, really. But do we continue to do caries prevention? At that point, you're really going to start thinking more about periodontal health issues as a lifetime development of positive behaviors that are going to impact your long-term periodontal health. A lot of questions have been raised by folks about orthodontics, and I'll talk more about that, but it would be in the usually late childhood to adolescence is the predominant time that happens. Then transitioning into later adolescence and adulthood, still looking at disease prevention. Periodontal disease will become even more important in the hypophosphatasia population. But if you have missing teeth, if you've lost teeth as a result of that, which is not an uncommon sequelae of that condition, then how do you replace those and what are some of the options? And I'll talk about those as we go through this. So preschool kids, again, diagnosis is a key. Genetic counseling and trying to figure out what's going on and how that can be best managed. It's critically important these days to make a diagnosis in hypophosphatasia because unlike not too many years ago, pre-2015, there was not a therapy and there is now. And we'll talk a little bit more about that. But and that's increasingly true for all kinds of conditions where we now have therapies where in the fairly recent past we did not. So making a diagnosis is really critical. Anticipatory guidance is a fancy way of saying that you have an exchange of knowledge related to optimal oral health. How do you prevent caries? How do you anticipate doing things that will not cause problems? Diet, fluoride exposure, brushing teeth, all of those kind of things. And so looking at what are the manifestations, if you're having loose teeth or you're having premature exfoliation, what's likely to happen with that and how are you going to manage that? Later in childhood, you can start thinking about restorative and prosthetic treatment. If you have missing teeth or you have caries or problems, that would be the restorative part. That's kind of how we manage kids. So things that we're talking about in that age group and the little kids is, one is it's recommended by the American Academy of Pediatric Dentistry, the American Academy of Pediatrics, the American Dental Association, that kids have a dental home by 1 year of age or by 6 months of their first tooth coming in, which is typically around 1 year of age. And again, we're looking at things like what are the caries risk factors. If you have enamel defects, which sometimes occurs in hypophosphatasia, that puts you at increased risk because the enamel on your teeth is the protective outer barrier. If it's rough and pitted, it makes it easier for the oral flora, the bacteria to grow in those nooks and crannies, harder to clean. Talk about diet. The American diet is sucrose rich. Even little kids drink a lot of soft drinks and juices and have dietary issues that can cause cavities. So educate folks about that. Salivary flow is usually not a problem with hypophosphatasia, but there are medications and issues where that can be a problem, and saliva is your friend as far as maintaining healthy teeth. Fluoride, there were some, I believe, some questions that had been submitted about that, and I'll talk a little bit more about it, but basically there's water fluoridation in communities. If you're on city water, in most places, about 70% of the population of the United States is on fluoridated water, either naturally or it's augmented. There are fluoride supplements, there's toothpaste, and there's varnishes and professional treatments that are much more concentrated. So all of those things, we put those together, you're trying to come up with a package that puts you on a health trajectory for positive oral health without having issues or problems. So tooth decay. I don't know if they can see my pointer. I'm hoping you can see my pointer on here. So if we're looking on this side of this chart, this is healthy teeth. These are little baby teeth. This is what enamel crystallites look like within the tooth. As you have acid production from eating carbohydrates and you move over, mineral will leach out of the teeth. They will, first thing you see clinically are these white spots, usually around the gum line where it's hard to brush and the plaque, the biofilm sits. As that continues and more minerals lost, the teeth will actually cavitate. The little crystallites are being dissolved away. They're getting ragged looking, and eventually you end up with big cavities and holes in the teeth. We can intervene all along this timeline to try and come up with ways to have optimal oral health and manage these problems. So a little bit about fluoride. So safety continues to be controversial. There's all kinds of stuff out there in the literature that continues to come out. This has been around naturally. It's naturally occurring. It's the 13th most common element in the Earth's crust. So people say it's not natural. Yeah, it's pretty natural. They discovered the effectiveness of fluoride just by studying municipalities that had naturally occurring fluoride in the water. So a lot of the studies were just done on those populations. It is one of the least expensive ways. It costs pennies to the person for community water fluoridation. Even fluoride toothpaste is relatively inexpensive by comparison to having to have a filling or a problem. So the evidence would suggest that it's very safe, which remains controversial, but it's very safe. And people have concerns about a lot of different things, but the preponderance of evidence is that it's safe. There's no question that it's highly effective in stopping tooth decay and it actually helps remineralize or rebuild the crystallites that are in there. And it's relatively inexpensive in most of its deliveries. So there are self-applied toothpaste, mouth rinses you can buy over the counter. These give you frequent. You can use a high frequency with this. So the exposure, the more frequent, the more likely it is to have a positive benefit. They are professionally applied. If you go to a dental office, they're gels. Varnish has gotten to be the big one these days, and there are other things, foams. Silver diamine fluoride is a product that came on the market in 2015 and is very effective at stopping a cavity from progressing. So it's not used predominantly for preventing cavities. It's used for stopping a cavity so that you may not have to fill the tooth, or you can use it to stop the cavity until you can get a filling put in the tooth. And I'll show some pictures of that. Appropriate use of toothpaste. The TV commercials, they show you having the great big loop-de-loop of toothpaste on there. You don't need that much, and you definitely don't want that much in a little kid. The permanent teeth are developing in children around the age of, well, they start in utero actually at about 6 weeks, and they continue to develop throughout life. But the permanent front teeth are developing from birth to around 4, the crowns of those teeth. And if they eat too much toothpaste, it can affect the tooth formation and have them have little white spots or even brown spots if they eat too much. But it's very effective if used in the right amount. So the guidelines, the recommendations based on the best available evidence is that this is a safe amount in a 6-month-old when teeth start to come in to a 3-year-old or even a 4-year-old. So you use just a teeny tiny smear or this little tiny dab after that age. So once they get to be 3 to 4, you can switch and increase the amount. Really, you don't need a whole lot more toothpaste than that for anybody. You could use a little bit more than that as an adult, but you don't really need to have the amount that they show in the commercials, but they're selling toothpaste. Some people, regularly, you'll see it listed as a grain of rice amount, so just a little tiny bit, or a small pea-sized amount, and that a small pea-sized amount, not a great big pea-sized amount. So critically important in little kids. Fluoride toothpaste works. It's very effective. It's safe if used in the right amount. What you don't want to do is use too much of it, because if you're using this kind of stuff, and I did these myself and I didn't get the pretty loop-de-loops out there because I was measuring it out of a syringe. But if you do these kind of things, and a little kid does this twice a day, they're going to eat a lot of it, and they don't need to be eating this. So use the smaller amounts. If you're doing this at home and the kid's putting it on themselves, they're getting too much. So toothpaste is 1,000 parts per million fluoride, and they're going to be swallowing and eating a lot of this stuff. So you don't want to do that. You should dispense it yourself and make sure that the right amount is being used. So use fluoridated toothpaste, but use it safely and wisely. Fluoride varnish has got 20 times that, so it's 20,000 parts per million fluoride, and it's used in very small amounts. Usually it's placed in the dental office, and it's about a 1/2 ml of the varnish is placed on the teeth to cover all the dentition. It's highly effective, and many randomized controlled trials to show the effectiveness. This is an older version that's kind of yellow. The newer ones are all white. But it's just a thin film that sits on the teeth, and usually they say don't brush or eat crunchy foods for 24 hours and let the fluoride soak into the teeth and do its job, and then you can brush it off your teeth. So that's out there as well. Silver is very antibacterial, and there are 2 silver products on the market in the United States. One is called silver nitrate. That's been around for years. It's been used in all kinds of medical applications because it is so antimicrobial. The silver ion is very effective at killing a broad spectrum of microorganisms. Silver diamine fluoride came on the market in 2015 in this country. It had been used in Asia, South America, and other countries for many years. It's been around since the 1970s, but it just came to the United States in 2015, was approved for use. And again, this is a product that's very effective at stopping a cavity that's forming. This can be very helpful in a variety of patients, either elderly or uncooperative, pre-cooperative, or don't have the capacity to cooperate for whatever reason with traditional types of dentistry and restorative work and those types of therapies. So this was a little girl that came in, and she'd had a crown placed to the dental office and wasn't real crazy about that experience. And she's got some cavities, and they're not real big. However, it's important in discussing this with parents to tell them, if we treat this with silver diamine fluoride, these will turn black. They won't be a little bit dark. They'll be black. She also had some cavities on the back sides of these top front teeth. Not real big, but they decided they would like to try and stop these and not proceed with more aggressive therapy, which in this case might have involved taking the child to the operating room or doing the sedation. So it's just painting it on there. It's painless. It's easy to do. She didn't like it that much, but it was relatively, it's inconvenient. They don't like it, but it's not painful. It's not uncomfortable. So we also use the varnish on top of that, so they get a double dose of, and here she is, she gets her tiara, so she's all happy now, everything's good. And we follow up on these and to see, have the cavities arrested and have they turned dark. So this is a month later, and these cavities are now dark and hard. They've stopped. And you can't really see much on the backside of these teeth, but there's the little black spots on the backside. So they can stay that way, or now it becomes a lot easier to go in there and maybe put some white filling over the tops of those without having to do so much drilling and injections and so many unpleasant things. Or if she's okay with that and doesn't mind the way they look and parents don't mind, you can leave them that way. So that's silver diamine fluoride, and that's a new therapeutic, relatively new, been around for a little bit now. I think somebody asked a question about pits and fissures and sealants, and so I added this in. This is, again, another preventive mainstay, and part of the reason is sealants are so important is because pits and fissures account for a very high percentage of the total tooth decay that we see in the population. They're nooks and crannies, and they're hard to keep clean, and so we frequently will see fillings in lots of the little pits and fissures. or, and this is why. So you'll see this is an electron micrograph of a molar. This is nicely coalesced, but you have all these little pits and holes in here where food can be packed in, the bacteria can hang out. And I know parents get frustrated sometimes because their kids will come in and they'll say, well, they've got a cavity in the top of this tooth. And the parents are like, I told you should brush them. You know, we got to get on the kid about this. But the reality is, this is a toothbrush bristle. I made this. I took a tooth, chopped it in half, and then took toothbrush bristles and set them up and did this scanning electron micrograph. You're never going to brush this out. So there's food and biofilm that are down in here, substrates for them to make acid, and so the cavities will start way down in here, and you can brush all day long and you'll never get this cleaned out. Sealants provide a protective barrier that'll block this and occlude this orifice of this. It won't penetrate down all the way down here, but it'll block this off so you can't get substrates down in there, and the bacteria will starve off and die. So that's how they work. So it takes care of these stagnation sites that are common in molars. So that's why you need them. We need sealants because your teeth are groovy, baby. Got to get my Austin Powers in there. Okay, so this is an example of a fissure, and this one actually, this dark is probably because it started to actually demineralize a little bit. And this is a sealant. This is a fluorescent dye used to track and see if this thing leaks if you put fluids or liquids and things in, which this one's not. So this is the occlusive barrier that you see from the sealant. They come in different colors. Some are clear, some are white, some are actually other colors. But this is an example of an unsealed with the grooves here and the little pits. And this is a white sealant where it's just flowed over top and occluded all of these surfaces. So this is from the American Dental Association. So they did actually it was a joint effort between the American Academy of Pediatric Dentistry and the American Dental Association, did a systematic review to look at the evidence on sealants. And what they found from looking at many, many clinical trials that have been done over many, many years, that you get about a 75% reduction. And so this was just a picture showing if you had 100 kids who didn't receive sealants, that's about how many you would have with caries. It's almost 50%. And if you not 100%, but about 50%. And if you did sealants, you would knock that down by 75%. So very effective. Again, that's the most prevalent decay that we see in the dentition is pits and fissures. It accounts for a disproportionate amount. So very effective. Again, like a lot of things, like fluoride and other things, people were concerned about some of the chemicals that were in there. There's BPA used to be in some of them. It's in almost none of them anymore. And those that it is, it's in tiny trace amounts. BPA is a bisphenol acrylic, and it's one of the components that it's not actually a component they use to manufacture. It's a byproduct of some of the reactions that take place. But the amount that you get in that is traced by comparison to what our exposure is to other things. But again, most of the current sealants in today don't have any of this in there. It's been completely removed in the process. They use different kinds of chemical processes to make it. So sealants are safe. People have talked about, well, you get cavities underneath of them. You can if they're not placed properly. That's why they, like everything else, should be monitored and evaluated. Most things are not one and done. Pulling a tooth out is one and done, but most other things need to be reevaluated and maintained over time. You may need to have sealants replaced, but they last. There are studies that have been out there 12, 15 years, and a very high percentage will last that kind of a lifetime. So that's the story on sealants. So switching gears a little bit to hypophosphatasia and tooth formation. So there are tens of thousands of genes that are involved in making teeth. Some of those genes are very tooth specific, and some have very different and critical roles in tooth formation. That is true for alkaline phosphatase, which is the gene that is the associated gene with the hypophosphatasia, and it's important in tooth formation for a variety of reasons. So the tissue nonspecific alkaline phosphatase is important for mineralization of craniofacial bones and in tooth formation. So because it's regulating the phosphates, which are critical in the mineralization of these tissues, these mineralized tissues, having it not function properly or not having an appropriate amount of it can cause abnormalities in the formation of these mineralized tissue. So premature tooth loss is one of the consequences that's fairly common in hypophosphatasia as a result of changes in the alkaline phosphatase gene. So this is a little fellow who's like 3 years old and has already lost his upper incisors and his 2 lower central incisors. He's lost 4 of these teeth. And that's certainly much earlier than you would normally expect them to be losing teeth. And sometimes it's earlier than that. Sometimes it's 18 months, and depending on the severity of the defect of the tooth formation. So the issue with the teeth falling out is, so these are thin sections that we made from teeth. So we cut them on a diamond saw, and this is the dentin, and these are little tubules, and this is the outer layer, which is called cementum. And it's a thin layer, but it's got little fibers in it that attach to the periodontal ligament and on the other side to the bone. In hypophosphatasia, that layer is not formed properly, so they don't have enough cementum. So the attachment to the bone that holds your teeth in is dysfunctional. And so consequently, the body doesn't realize that the tooth is really attached because it's not really attached very well, and they will get loose and they will fall out. So again, normally this is the periodontal ligament. These little fibers, you can kind of see these little white strands that are attaching into the cementum. Those attach into the fibers, collagen and other fibers within the periodontal ligament. And on the other side, they would be attached to the bone. That's the sling that holds your teeth in your head. And in this case, with hypophosphatasia, to varying degrees, depending on the severity, this will be not as well formed and you don't have this fibrous attachment. The sling is not working properly. So tooth loss, premature tooth loss occurs in all the different types of hypophosphatasia. Frequently, well, on average, this is data from Michael White, who's done probably more than anybody else, has published on this topic and has more of the dental information than anybody else, but usually the second year of life. So around 2 is when this frequently starts to happen. Most commonly, it's going to start with these lower incisors. Tends to be earlier and more severe forms, and more teeth will be lost. This little fella you can see has already, well, I don't know if you can appreciate it, but the gums are receding down off of this tooth, which is a canine, and it's already starting to get loose. This is a fairly severe. This young fellow also has a bite issue where his teeth are not meeting in the front and his arch is a bit constricted. And I'll talk a little bit more about that as well. So the number of teeth that are lost go up as the severity goes up as well. So another little fellow. The radiograph X-ray will show that the root is on this tooth, even though it's getting loose. Normally, baby teeth, the permanent tooth is coming up. The baby tooth root dissolves off as the permanent one's coming up, and then the crown falls off, and there is no root on it. In hypophosphatasia, this is what happens. These permanent teeth are not coming up yet. It's just this is getting loose because of the lack of attachment, and it will fall out. This another electron micrographs now, nice fibrous looking cementum layer, and this is the hypophosphatasia. Not only do they not have the fibrous layer, but the dentin underneath of that is not as well mineralized as it would normally be. Here you can see it looks nice and dense. Here you can see it's all kind of porous looking. That, I think, comes into play with the issue of getting cracks and having problems with that, with your teeth in that regard. Now, I'll mention that a little bit too. So here's the teeth. These are teeth from one of these little fellows that I saw, and they came in, and I was playing the tooth fairy, but here you can see that the teeth, there's full root on these teeth, essentially. They will have little loci of resorption. That's what this is, again, seen with the electron micrograph. But normally this would be gone. The whole root would be dissolved away. So that's not the case. That's a big red flag. It's occurring early, and they have roots on them. That's not the normal natural history of the way teeth work. So we have cementum issues. The dentin is the inner part of the tooth. The enamel is the hard outer shell for the crown. This is the crown. This is the root. And you can see the pitted appearance of this. So in some cases, not in all, but in some cases, you can also have enamel defects And again, this can lead to problems with tooth decay or aesthetic kind of issues, depending on the severity and where these pop up. So that can happen as well. Here's a case report in the literature, and again, here you can see this open bite in the front, and this little guy's got these yellow-brown hypomineralized areas in the enamel. So it's a combination of problems of enamel defects, and also he's got this bite issue, which not well documented, but it pops up, and I've seen it in a number of patients, and you see it in these case reports that are in the literature. So how do we manage this when you have these kind of defects? Sealants is one way to help prevent from getting cavities, and I do that in some of these cases, and that can be very effective. Fluorides can be very effective, and if it's an aesthetic, like in this little fellow, which is not hypophosphatasia, but you can put bonding over these and make them aesthetic. So there's a variety of ways that you can manage that. Optimally, you would do it preventively, but if you need to, you can do it restoratively as well. People asked about cracks. So cracks occur in teeth, and they're much more common in elderly people's teeth than they are in younger people's teeth. If you hit a tooth, or if something happens and you get some sort of a trauma to the tooth, it's not uncommon for there to be a crack in the tooth. And they can be a partial crack that doesn't go all the way through the thickness of enamel, or they can go all the way through. Some people have concerns about these as being a conduit for bacteria to get in the tooth and cause problems. That's not so well documented. But what I think it is a problem is that it may be a harbinger for you're going to have a piece of your tooth fall off at some point in time, as is illustrated on this, or illustrated on this molar where there was a filling which weakens the tooth because there was probably a cavity on here, but this whole backside broke out and chunked out, and teeth can crack all the way through. In hypophosphatasia, it's not documented that this is a greater problem than it is in any other part of the population. However, because there is a dentin component where the dentin is not as well mineralized, the relationship between the dentin and enamel, the support that dentin provides, may not be as optimal, and that actually could be one of the causative factors why could be more cracking in teeth of people with hypophosphatasia than in the general population. Again, there's no study has been done on that, but I could easily hypothesize, and it's a testable hypothesis, that may be contributing. I mean, I have to say I had a back of one of mine break off like this, but I was eating some of my wife's delicious praline stuff for a Christmas salad, and I bit down on a piece and broke out a chunk of my tooth. But so it happens a lot to other people, but it could well be more prevalent in hypophosphatasia. Not been studied though. And what you do with those is, with these, you could put a sealant over this. This, you would have to replace that probably with a crown at this point on that tooth. If the tooth is cracked all the way through, there are some things that are done, but not uncommonly, it's take the tooth out and then figure out how to replace the tooth. So what about periodontal issues? So people have looked at the periodontal flora that are associated with periodontal disease. And this is the only study that I've seen where they actually did this. And they were looking at healthy controls and the people with traditional periodontal disease that didn't have hypophosphatasia, and then hypophosphatasia. And the bottom line is, in this graph, the black is hypophosphatasia, the white is controls, and this column is the periodontal disease. In most cases, the hypophosphatasias are very similar to the controls. They're not the same as the people with traditional periodontal disease. So the good news is that you are having tooth loss not because of the periodontal disease part of it. In most cases, again, that was only 7 people, but you don't have it's not that you've got a preponderance of having an unusual microflora that's helping contribute to this. It's just that you have an attachment that's not as well established, which puts you at greater risk to have tooth problems in the future. So what do you do about that? So you want to prevent the tooth loss related to periodontal issues in there by reducing the inflammation that's caused by having the biofilm on there. That's what periodontal disease is. So in this picture, this is tartar that's formed down here, and here it's cleaned off, and you can see the gums are red and inflamed underneath of it. So very strict cleaning, and that will certainly help and should be maintained throughout life. Anybody with hypophosphatasia, you want to be rigorous about your hygiene and trying to limit any inflammation from the biofilm that's in there. Enzyme therapy, now that there's aspartase, extrinsic, there aren't any studies on whether or not that's going to prevent tooth loss or periodontal disease. In the animal models, it looks very promising, but it hasn't been around long enough to see the long-term results that I've seen from any human studies. It's not in the literature. So when you go to the dentist, what they're usually looking for is we have these little, it's called a periodontal probe. It's a little measured. There's plastic ones and metal ones. These are millimeters. That's 3, that's 5, that's 8, on up. And they're looking, normally the attachment of the gingiva is right around the collar of the tooth. And then this is the bone. As you have irritants in here, biofilm, that causes inflammation. The body responds to that, causes inflammation, and you'll have regression of the attachment and then ultimately of bone. So the way you manage that, flossing, brushing and flossing. Floss is great. There are other things as well. If you're already having issues, there are all kinds of little proxy brushes or little stimulants, things that you can put between your teeth to help clean between them. But you just want to make sure that you keep the biofilm off. Even if you have this problem, you can get to the point where you can keep this clean. You can stop that inflammation and stop the bone loss. Hypophosphatasia, this is going to be a bigger problem because the fidelity of that attachment is not as strong as it would be in someone that didn't have hypophosphatasia. So missing teeth, how do you do that? So there's different ways you could do that. There are fixed and removable kinds of appliances, dentures, overdentures. You can do bridges depending on how many teeth and where they are and how you manage that. Not a lot of information in the literature on this, so there's just a few case reports. This is one because people often ask about implants and will they work or will they not work. So in this case, they had a couple of cases and they had 3 mandibular implants. Mandibular implants tend to be more stable than maxillary in the bottom jaw compared to the top jaw. They'd been in there for 13 years. They had one of the upper jaw ones had failed. So you can have them, but you probably have bone that may not be quite as, if you're not on therapy, it may not be quite as dense as it would be otherwise. So they might be a little less successful, but there's no data out there really for me to guide you and say, well, based on a whole bunch of cases, this is what we're seeing. There are a couple of successful cases in the literature. So it's something, I'm usually feel like you have to weigh the risks and benefits of these things and decide, is it worth the gamble and the money and the surgeries and all to do that if you really want to have it, and then will you take care of it? Because if you have an implant and bone that's not quite as dense and solid, you can have inflammation around the implant just like you can have around the root of a tooth. So it doesn't preclude you from not really having to take care of it. You will have to really take care of it very carefully. So that's what we know and don't know about implants. Implants are basically screws. The therapy on this is a lot better than it used to be. They know a lot more about them, the size, the shape, where to put them, how to put them. The aesthetics of these things have gotten a lot better than they were a decade ago even, and that'll probably continue to improve over time. So it's an option. There are craniofacial features that you can see, and they're highly variable depending on what you have. There's occlusion, as I said, this little fellow, these top teeth are below or inside of the bottom teeth. Normally they'd be the other way. The front teeth wouldn't come together even if they were there. That's what we call an open bite. So, and he's got other issues related to his stature and craniofacial features. So highly variable, the morphology, you can have craniosynostosis, the head shape may vary, and this anterior open bite, which again is not well documented in the literature. So this is a little fellow who has some of these issues. This is out of a case, this is one of my patients. This is out of the literature and again, a case report, and they're showing the anterior open bite in this adult. So how prevalent that is, I'm not sure. The midface is probably not as well developed either, which is common craniofacial variant you see in a lot of different conditions. So yeah. the cephalometrics is how the orthodontist would usually look at these things, and that was a kid and this is an adult. So ortho treatment, people asked about that. Can you get braces? Well, it again would be one of those risk benefits alternatives and things. And do you do traditional? It is no question that this is going to enhance the biofilm sticking on your teeth. And it's also going to challenge the attachment of your teeth because it's going to be readjusting as your teeth are moving through that. Now, having said that, again, depending on the severity of the bite, how far you've got to move the teeth, depending on the severity of the hypophosphatasia, you could have orthodontics and may have it without any untoward effects. I would proceed with caution if I was doing that. Would make sure I kept them immaculately clean and not like this little kid who's got bleeding gums here around these things. That would be a bad thing to have happen. And just go into it knowing and have a really good periodontal examination beforehand and monitor it very carefully and be ready to bail out if you're having a reaction that's, you're having a negative result. People ask about Invisalign. Invisalign are these clear, what they do is they actually take a scan of your teeth for an impression. Frequently now they're doing this digitally, and they will set the teeth up or they will move them into a more ideal, and then they'll make this this little stent, this little clear plastic, and you bite into it, and it's moving the teeth to where you had set them up for them to be. So you can do it very slowly and gentler and kinder. There's no data whether or not that's going to be less problematic than it is the other way. Easier to clean, no doubt about that. So, that this has gotten to be fairly popular as far as a therapy. And if you had that as an option and it would get you where you needed to be as far as the aesthetics, and usually orthodontics is largely for aesthetics, not completely, but largely, that might be a good option to consider, if for no other reason, just the ability to clean so much better. A downside to this is if you don't wear them, they don't work. And I've got kids who can come in and they don't work, so their teeth don't get straight. So that's a downside. You have control the other way if you do that. Not a lot known about the adult dentition. There's more known about tooth loss, and that's one of the really kind of the main data that we have. There are reports, this is one out of Duke where they're looking at adults, and there were a high percentage, or 75%, that said they'd had dental issues. Whether or not that's different than the general population or not probably is a little bit higher, but it's not well defined. The bottom line of that is there's opportunities for more work, but if you don't have good oral health, you still don't have good health, and oral health is a nice thing to have for sure. So the dental team, when I go and speak to dental folks, is they're frontline diagnosticians, especially for the kids, but maybe even in adult populations where they haven't been diagnosed, and that does happen. Looking at the dental manifestations can be telling and can be diagnostic, at least enough to raise the clues that you should be evaluating, maybe need a deeper evaluation. Age 1 dental visits for everybody, I would highly recommend that, especially for hypophosphatasia kids, just so, one, you can prevent tooth decay, and two, so you're preventing all of that, and then you can monitor and hopefully be on a healthy trajectory. And it will be interesting to see how the treatments will affect the kids' dentitions. And I would assume that data will be not too far in the future, because that's been out for about 5 years now as well. So we shall see. There are registries and things which are important, and that was brought up at the beginning about a registry. Registries can be very helpful in tracking patients and getting information, doing surveys and those kind of things, because after all, it is you folks that affected individuals and the families that have the information that that would be so helpful in elucidating some of these questions that you're asking that we don't have the answers to, because we just don't have the data that's out there. So registries can be extremely helpful in that regard. So it's a lifetime endeavor for everybody with oral health. There are greater challenges with hypophosphatasia, no doubt. The issues related to early tooth loss that in some individuals will continue throughout their life. They'll be more at risk for losing teeth, losing them easily. like trauma can take out a tooth, whereas normally that wouldn't happen. Periodontal disease seems to be, although again, not a lot of data on that, but seems to be more prevalent and more of an issue, and how to manage that. So it's something to stay on and be vigilant and be aggressive in trying to have the very best preventive care that you can. And then considering options for things like implants or orthodontics and things that may help help you have the very best oral health and the best aesthetics that you can possibly have that make you feel good about yourself. So with that, I would be happy to open it up for any questions, which they are going to apprise me of, and I will do my best to answer.
Terrific. That's great. Thank you so much, Dr. Wright. That was so much good information, and you covered off on so many questions that we had, so that was really great. We did have a couple questions come in. As you know, obviously, a smile can be the root of confidence for many kids, and having a chipped tooth or a missing teeth can really impact a child's self-esteem as well as an adult. Any advice on the ability to do some of these, those restorative dentistry techniques that you talked about, specifically regarding crowning or filling HPP teeth?
Sure. So in real little kids, it's surprising sometimes how young the kids are very attuned to their appearance, and kids can be very cruel to each other. 2-year-olds, not usually so much. They don't really care that much. They just know how to say no and do what they do. 3-year-olds, surprisingly, and certainly by 4, frequently kids have a very strong self-awareness about their personal image and their smile. There are things that you can do. That we have beautiful zirconia crowns. If you get cavities in the baby teeth, the front ones, we can do those, and they're beautiful and white. Those have been on the market now for maybe 8 years, something like that. So we do a fair number of those. If they're missing teeth, there are a couple of ways that you can address that. And usually my first thing is it important to the child? Because they're the ones that are going to have to sit there and put up with whatever you're doing. But there are appliances that can either be fixed or removable that you could make to replace front teeth, for example, top front teeth. Bottom ones don't typically show so much. Some kids do really, really well with that, and they're really into it. Others could care less. They don't want to be bothered with it. In fact, some kids with missing teeth may actually even like it. It's part of who they are. Kids with ectodermal dysplasia are frequently missing a lot of their teeth. Some of them really want teeth. Some of them really don't care. They don't want teeth. They don't want to be bothered. The ability to do that kind of treatment, one of the issues with the fixed ones is you would anchor that off of baby teeth. That would put those teeth at risk. It would put new stress on them, and that would be somewhat of a concern. Doesn't mean you wouldn't do it, but you want to proceed with caution. A removable appliance would put less stress on the adjacent teeth that are remaining, but usually you're going to anchor that off of some of those teeth as well, but it would be less stressful. There'd be a number of ways to do that, and the way I usually manage that is I'm trying to figure out what it is that's what does the child really want? Is this something that's really important to them? Because if it is, then I think we need to bend over backwards to make it happen for them so they have the best self-image they can possibly have.
Okay, great. And then what about some of the other, in terms of hygiene and other popular cosmetic treatments such as, tooth whitening or even a water pick? We had some questions around that. Any specific guidance that you have around using a water pick versus traditional flossing, or what is your guidance on tooth whitening?
Yeah, okay. Well, I'll take tooth whitening first, and then I'll go to water pick. So tooth whitening, again, frequently, especially in little kids, they usually don't care about the color of their teeth so much, and usually baby teeth are very white. And when the permanent teeth first start to come in and they're up against those baby teeth, they tend to look yellow because they are by comparison, because of the size and the bulk. The optics are different. So teenage kids, young teenage kids or late childhood kids may come in and say, my teeth are so yellow, I hate the way they look. First thing I usually do is actually get a shade and say, okay, this is kind of a standard average kind of a color right here. and some that satisfies and others it doesn't. The bleaching that you do, like the Crest strips and the over-the-counter, all of them are basically hydrogen peroxide based. They have other chemicals in there, but they break down the hydrogen peroxide. That will perfuse through it. The ions will go through the enamel and actually through the dent and can get into the pulp. My take on it is, if you really have a color problem, then there are different ways you might deal with it. Bleaching might be one, but I usually like to hold off until they're a little bit older, and that would be like, maybe in the teenage years. So that might be an option, not something, there's nothing really in the literature on kids younger than 8 or so where bleaching has been done. So it's an option, and I usually start with the least concentrated bleaching and see if you can get them to a point where they're happy with that. And there's in-office bleaching things that you can do as well. And if they have a specific brown spot on a tooth, sometimes you can just do the brown spot and get away with that. And there's a variety of things on the market and available to the dental profession to whiten and take care of discolorations. As far as, what was the other question? It was, what was the other one? I forget now.
It was bleaching and the water pick.
Yeah, the water pick. Okay, great. Yeah, I was thinking of the commercials I've seen on TV lately with the toothbrush water pick. It's all in one, and they've got the corn on the cob with the stain in it, and the regular toothbrushes and getting it all out. Water pick is an easy, maybe an easier thing for a lot of people to do. The bottom line is, though, that the water pressure that's in there, blasting it out, it'll get rid of the big chunks and it'll help reduce the amount of biofilm, but it doesn't really get the biofilm off as effectively as dental floss or some of those like proxy brushes and some of those things that you might want to use. If you can get a kid to use that and they'll actually keep their teeth clean, or a teenager with braces, yeah, those can be effective things. In fact, you can put fluoride mouthwash instead of using water, use a fluoride rinse and have them blast that around in between their teeth and clean around them. So it's not that they don't have a place, but it doesn't really, it doesn't totally take the place of the mechanical plaque control that you can do with dental floss or a brush, a toothbrush or a proxy brush or some other mechanical device. The water alone, there's not enough pressure. It still leaves biofilm. Thinner layer, but it still leaves biofilm.
Okay, that's great advice. I never thought about the fluoride treatment into the water pick. There are some questions about, there are children that appear to have the early loss of their deciduous teeth, but others that tend to have loose teeth, but they don't come out necessarily on their own. And we have some reported cases of abscesses and people who have to have their teeth pulled in HPP. Is that something that you see specific to HPP, or is that maybe an anomaly that might be more applicable to the general population?
Yeah, I'm not aware of any studies, and I haven't personally seen that. I don't know that I've ever had a patient with HPP, a kid with an abscess. There are other hypophosphatemic rickets and things where that is a highly prevalent manifestation of that condition and other conditions. Certainly if you get tooth decay and it goes down inside the tooth to the nerve, the pulp and the inside of the part, then you'll get an abscess with that. And everybody has, that's a common in the general population. Tooth decay is the most chronic disease in the human population. And if you have hypophosphatasia, you're not spared from all the other stuff that you get that everybody else has. You got that on top of, having hypophosphatasia. That's why you want to control it as best you can. As far as the teeth coming out or getting loose and not coming out, there's probably just still enough attachment that they don't come out. Now, sometimes you have baby teeth when the permanent ones are coming up, and I talked about the root dissolving away and then the crown falls off. Because of the positioning of the permanent tooth to the baby tooth root, sometimes they don't do that efficiently, and there's still baby tooth root. This is very common on like the lower incisors. So the permanent teeth will come in tongue side, on the back side of the baby tooth. The primary incisors will still be there. They look like they've got shark teeth, so they've got 2 rows of teeth. Usually that resolves on its own over the course of 6, 7, 8 months, but sometimes there's so much root left that those teeth need to be extracted. And it can happen in other places. That's just the most common place. But that's
Okay.
that's not an HPP phenomenon. That's just a general
Okay.
phenomenon.
Okay, good to know. We have some questions about HPP cases in adults and whether or not permanent bridges can be used. Are there any additional problems that you see with adult teeth? You know, do some adults also have tooth loss or problems with the quality of their teeth? Any comments that you have on that particular topic?
Yeah, so there's not a lot of data out there. That one study that I showed was the only one that I've been able to find. There's very little out there. There's a few case reports, but there's not a lot out there, which is why it'd be a great thing if we could survey people in a registry and actually get at least their self-reported issues related to that, because there's not much. My guess is, though, that from, and even just talking with some of the adults that I've met at the meetings, like at the one in Chicago, and I chatted with a young lady who was an adult HPP, and she said she'd had all kinds of issues. And I think that if you talk to people in the audience that are adults that have adult HPP, that they would probably tell you that they do as well. Some of that's just because they've got regular dental issues like everybody else, but some of it is probably because they have HPP because, one, the teeth are probably may not be as well mineralized. Two, they may be at greater risk for periodontal issues. So, I mean, I've talked to parents in autosomal dominant families where they have lost permanent teeth with very light trauma and lost a lot of them. I've talked to some where they had orthodontics as adolescents and they really started having problems after that. As far as bridges and things in adults, it's just caution, be cautious and have things evaluated really well. Get a practitioner, make sure that they understand what you have, and they may not know. They're not going to know either because there's not a lot of data about permanent dentition. But make sure that you're dealing with somebody who is that you at least would ask somebody. I mean, they could call me and I'd be happy to talk to them about it and say, hey, these are things that you ought to be on the lookout for. Be on the lookout for periodontal disease if they have it, and if they don't have it, to monitor to make sure they're not getting it. Because if you put a bridge in, you're going to put new stress on a permanent tooth that you're butting it off of. You've got to have your pillars of support. And if those are compromised because of HPP, you want to be very careful about not messing up what you already had. So those are how I would proceed. I wouldn't not proceed, but I would just proceed with caution and go about it that way.
Great. I think we have time for one last question, and there's, as you know, several dentists who have tuned in to the webinar tonight. Lots of questions about advice for dentists and how they should be communicating with primary care doctors of these patients if they suspect a case of hypophosphatasia. What kinds of labs to request, any main issues that the pediatricians should need to be looking for, and any other kind of diagnostic criteria or information they should be sharing. So I thought that that would be an important point to address on the call.
Yeah, that's a great question. So part of it, and it's probably a long answer, but there are certainly a variety of tests. The alkaline phosphatase serum levels is one, urinary phosphorethanolamine is another one, and there's genetic testing. And then who do you go to? So in my case, I'm a pediatric dentist. I would be talking to the, I would definitely want to have in the loop the primary care pediatrician. But I also might, depending on, and I might just suggest to them and say, I think this is a case where maybe it's the peds endocrinologist that you really want to have because they're good at monitoring some of those things. The evaluating and having the tests run. It'd be much more in their realm than it would be necessarily a pediatrician. And you could be a direct, I tend to direct refer to genetics a lot of times, but I have a very close working relationship with them. But part of it depends on your community and where you are and what the patient's comfortable with. Certainly think your primary care people have got to be kept in the loop, but that doesn't mean that you wouldn't necessarily call in other people, or at least make that suggestion to the primary care person that you think that would be in order. I usually don't recommend the test. I figure they'll know that. I mean, I can if they want, but I usually let them take the lead on that.
Great. Well, that brings us right to the top of the hour. So that's all the time we have for questions, but we have captured the remaining questions and we will pull together the answers and share them with you after the presentation. So we want to make sure that all of your great questions and great engagement are addressed. So thank you for submitting those, and we will be following up with some sort of a communication after the webinar, working with Dr. Wright to make sure that we get those questions answered. So with that, I want to thank you for joining us this evening. If you did find this webinar valuable, please consider making a donation. And we wish all of you continued health and safety during these uncertain times. And we appreciate your engagement during the webinar. Karina, back to you.
Thank you, Deborah, and thank you also, Dr. Wright, for your informative presentation. And on behalf of Softbones, we'd like to thank everyone for taking the time to join our session and enjoy the rest of your evening.